Good morning. It's a pleasure to be here. It's also a little bit stunning to see so many people in British Columbia concerned about the issue of healthcare reform, of the way in which health policy issues evolve. I'm used to thinking of this as a small group of people in a small room somewhere. So it tells me that something is underway here. What I'd like to do this morning is to give you an overview of what's happening on the European front in terms of the broad range of reforms taking place in the many different countries of Europe. And as you're well aware, the patterns vary depending on the country we're talking about. But to give you a feel for what's taking place in other developed countries and something about the potential implications in the Canadian context. The parallels obviously are not exact. While as predecessor speaker mentioned, Canada does have a tax-funded healthcare system, and in that regard, at least on the financing side, looks like the Northern European countries, Britain, the Nordic countries, and also the southern tier of Western Europe, Portugal, Spain, Italy. There are considerable differences. One of the differences I noticed yesterday walking around downtown Vancouver, you have construction cranes, you have buildings going up. I haven't seen that in Europe in at least 5 years. So there's obviously different economic issues involved here. We'll get into that in a minute about the European perspective. Nonetheless, there are patterns that suggest in Europe that we are entering perhaps a different era in terms of what healthcare systems will be able to do, the expectations that citizens have as well as patients have from their healthcare systems, and that the policy options are changing, and perhaps not changing in a good way. You'll see from the presentation that this is not an entirely happy discussion. It's certainly not a happy discussion in the European context. Nonetheless, it's one that is driven by practical reality. And so it's a question of grappling with it. With that said, if we move on to what the picture looks like across Europe, the broad framework here, broad strokes. Really since the 1980s, European policymakers have had a common set of objectives. They're very similar to the sorts of issues that are regularly discussed as goals and objectives in the Canadian system as well. You've seen this before. Equity in terms of universal access, efficiency of performance, effectiveness in terms of delivery structure, accountability in terms of being responsible for what you do. And in the last 10 years, this whole issue of good governance has bubbled to the top and become a major international issue in Europe and more broadly globally. Anything that is proposed in terms of reform or proposed in terms of change is typically judged or measured against that set of objectives. The usefulness of any proposal has to do with whether it is seen as advancing those objectives. So that's the conceptual framework that has evolved over 30 years and is broadly accepted across the political spectrum, really, in most European countries. The dilemma then becomes, how do you pursue those objectives if, in fact, the growth of revenue to do it with is shrinking, diminished, or stopped? How do you do that if there's not going to be enough money, if in fact we're living in a period of what a graduate student of mine referred to as prolonged austerity? I was less optimistic. I started out referring to it as permanent austerity. with, as you'll see, the assumption that the post-World War II welfare state was something that emerged in a period of history based on what economic revenues and development would support, and that we now have moved into a different period, and that prior period that the welfare state depended on has passed. That raises the key question, really the topic for the entire presentation, which is whether austerities move the goalposts. Are we no longer looking at the same set of objectives for our healthcare systems in the ways that, that I laid out in the first slide, in the ways that have been taken as gospel in Europe? And if the goalposts have been moved, then what are the alternative ways of reaching some of those objectives? Can we get there by other means than the ones that we have been pursuing? Or do some of these objectives have to be altered? Do we have to rethink how those objectives might be achieved? And more importantly, are we talking about temporary changes? Are we just adjusting to a short-term economic problem? Or has something more fundamental shifted, which is the question about how long that austerity lasts. All right, I'm going to take you through a quick set of slides about the economic substructure that generates the revenue for healthcare systems. Many of you will know these statistics. It doesn't make a happy picture, but it's important in terms of understanding the implications for what healthcare reform is capable of in the current period. As I'm sure most of you are well aware, the dilemmas really became visible, came up into public prominence in September of 2008 when a decision was made to not bail out a bank. For all this discussion that bailouts are part of the problem, this is the unfortunate reality that it was the lack of a bailout that at least triggered off the immediate impact of the economic crisis in 2008. A lot of very unpleasant consequences, as you're well aware. For our purposes now, in 2014, the important question is that 5 years after that onset of the crisis, from a European perspective, there's still minimal growth. In fact, only in the last 6 to 9 months has there been any growth. And that growth is very slow, very painful, not adequate to even pick up new entrants to the workforce, never mind to hire back prior unemployed populations, people who lost their jobs and so forth. If you, I don't know which screen to point at here, if you look at these statistics, if you look at the entire Eurozone, which includes most of continental Europe, 2013, the entire GDP growth was still negative, 5 years after the onset of the crisis. Canada, of course, has been doing somewhat better. That's one of the reasons I said Canada is not a direct parallel to the European situation, but perhaps that's something we can talk about in the question. In the question period. No, that's not going to work. Sorry. The only country that has started doing a little bit better in 2013 is Britain, and even that is weak and tentative, 1.8% for the year. That's not exactly a strong economic rebound from a period of no growth. If you look at, this should say income per capita, that has also stagnated. Canada, the United States running around 50,000. Netherlands is still at 50,000 in the UK. But if you look at what's happening across Germany, France is the same as Germany. Those are not equivalent figures. The revenue base that you work from is deteriorating. Actually, if you look at Southern Europe and until this year, the UK, certainly Ireland, you see that the actual size of the economies is still smaller than what it was 5 years ago, 6 years ago. It's not only a question of not growing, the economies actually have been shrinking. Sovereign debt continues to rise as a percent of GDP. Almost everybody, except for Canada, I believe, and certainly the United States, is over 90% of GDP, many of them well over 90%. There's been recent research from Carmen Reinhart, which strongly suggests that, and it's been disputed, but nonetheless she's gone back and redone the statistics, strongly suggests that if your economy is if your sovereign debt is over 90%, it dampens, it reduces your growth potential, your ability to improve your economic position, and from our point of view, raise new revenues that can be used in the health field. If you look at budget deficits, that's just adding more debt. That still goes on in Europe. If you look at the total Eurozone government debt between the onset just before the crisis and now, it's gone up by nearly 50%, continuing to grow. I warned you these were not happy statistics. If you look at the unemployment rate, that story you know, it's extremely high. The figures in the United States are a little bit illusionary. We still have a long way to go to get back to 2007. And as many of you know, increasingly people are pulling out of the workforce, so our numbers are misleading in terms of what's actually happening. A couple more slides here. This is a headline from the Financial Times last October, in which it talked about the next year's budgets coming from the UK government. The headline is UK's 6 more years of austerity, following on 5. Headline subsequently, a week later, the International Monetary Fund warns the world faces years of low growth. Okay, I just wanted to throw all this at you to give you the sense of what the broad economic framework is in the European context. When policymakers sit down and say, well, what are we going to do with our healthcare system? What are our options? What is possible? One final sequence. And I hope you can see this at the back of the room. I'm not sure if that's possible. But these are 4 slides from the Financial Times that look at the total contribution to growth in the world, economic growth in the world, as is being made by different countries in the world. And also, very interestingly, up here at the top is the split between emerging countries and what they, for reasons I don't know, call advanced countries. Perhaps we might just say developed countries. There are 3 different series here that you might look at or pay attention to as we move through all 4 slides, starting with the 1980s and moving up to projections for the next 5 years. One sequence, of course, would be Canada, which in the 1980s was 2.6% of total global growth. Second sequence would be Europe. And here, if you add together the UK, Germany, and Italy, it's over 10% of total global growth was being generated out of Europe in the 1980s. You still had this process that had started from the 1960s in terms of Europe being playing a major role in what was happening globally. The third sequence, as I said, is between the overall balance between emerging and developed economies, and it's more than 2 to 1 in favor of developed economies. 69% was being generated. 69% of growth was coming out of Europe, the United States, Canada, the OECD countries, okay? If you continue on in the 1990s, you notice that on sequence number 1, the Canadian number falls. On sequence number 2, the European sequence, it goes from over 10%. Germany and Italy disappear in the 1990s. They're no longer adding to global growth. They've fallen into stagnation. The UK is still here, 3.8%. But Europe has dropped down to 1/3 of what it was. If you look at the balance between emerging and developed countries, it's now become almost 50-50. In 10 years, it's gone from 2-to-1 to 50-50 in terms of contributions to global growth. If you come up to the first decade of the 21st century, Canada's disappeared. Canada no longer adds to international growth. Europe has a shrinking UK, but it's still at least on the map. And if you look at the relationship between emerging, this is refusing to stay on, between emerging and advanced up here, I guess you're going to get bouncing light here. It's now become 2/3 for the emerging and 1/3 for the developed world. If we move to the projections, and these are projections, based on the best economic evidence of what's coming over the next period of years, from 2012 to 2017, what has happened, of course, Canada's gone. Europe is now gone. Great. Thank you. Europe is now gone. Europe is not adding at all to global growth in the next 5 years, okay? And if you look at the balance between emerging and developed countries are now down to 1/4, 25% of the total. They've gone from over 2/3 down to 1/4. The lesson that comes out of this for health policy making is really very obvious. You're not going to have the revenues to deal with. The economy is not growing adequately in order to throw off the revenues that you had planned on when you set up the structures of the existing arrangements for your healthcare system. The game has changed. We can talk about why or how, and macroeconomists like to play around with strategies, but those facts remain. First question, how long is a crisis still a crisis? When does it become the new normal? When do you say, okay, it's not going back to the way it was before? We are in a different era. Second set of issues has to do with how long can public spending for health be protected? This is something that people talked a lot about in the first years after 2008. We have to protect social spending. We have to protect health spending. It's important to protect, and I'm going to say this, I'm not against this, I'm just simply going to repeat the language. It's important to protect vulnerable populations. I believe that's true. But how long can you do that with public spending when you're not generating the money anymore? How are you going to provide higher quality services? How are you going to meet a constantly rising international standard of clinical care? How are you going to do that if you have slow or actually reduced public funding to do that? What happens about the citizens' willingness to trust that government is going to be able to keep its promises? What happens if government continues to make promises that the revenue base is not going to support? So that raises the obvious, takes us to the obvious question, which is in essence the subject of today's forum, the rebalancing of health systems, which is how do you restructure systems in a way that meets what is a different, new, at least long-term financial picture? How do you minimize the damage to the agreed system objectives? How do you minimize the dilemmas to those, to the weakest members, the most vulnerable members of your population? And how do you create sustainable institutions? That word sustainable is becoming something of a yoke around the neck of European policymakers. How do you make health systems sustainable in this revenue environment? One of the things that you then have to start to think about, and this is a painful process, is what changes need to be made in terms of how we've looked at the health policy issues up until now. You have to reconsider what we have decided was acceptable, socially acceptable, politically acceptable in terms of a whole range of different policy issues. There's the whole debate about rationing, the whole debate about efficiency. How are you going to generate efficiency? How are you going to get public sector institutions to become more efficient? How are you actually going to do that rather than just talk about it? Which certainly in the European context is a major issue, particularly in the tax-funded health systems. It changes around the whole decentralization, re-centralization debate in terms of what you're trying to maximize. It certainly has an impact on the co-payment debate. It has an impact on what's considered good stewardship, what's considered good governance. Is good governance maintaining the old structures, or is good governance preparing sustainable systems for the future? What about primary care? The last 20, 25 years in health policy in Europe, but also more generally, has been one which has said that hospitals are necessary, but they only cure. We need to shift more resources and more emphasis into primary care and to keep people out of hospitals and to build up primary care systems. What happens to that argument if there's not money to build up primary care without actually doing damage to your ability to provide clinical services? It's what happens when it's no longer a win-win kind of picture. The whole issue about giving hospitals, public hospitals, semi-autonomy. That's not, I don't believe, an issue in Canada, but it's certainly an issue in large parts of Europe. In other words, allowing the hospitals to make their own decisions, even though they're publicly owned, separate from political decisions. What about this question of generating more co-production on the part of patients? What about the whole issue about the role, the balance between the state on the one hand and civil society on the other? The relative responsibilities in the whole health sphere. All those come into question. Also coming into question are the more recent debates about social responsibility. For those of you who follow it, the Marmot Commission and social determinants of health, the efforts of the epidemiologists to argue that funds and effort has to move, quote, upstream into prevention, into social prevention, to housing, to education, to prevent people from turning up sick 20 or 30 years later in the healthcare system. How do you fund that in this environment? What's feasible? Obviously, there are a lot of caveats. And when I said I was painting with a broad brush, it's very true. Some countries now have slow growth. There are big differences amongst the different countries in Europe. There are broad system objectives that work differently in different national contexts, different national cultures. There's also a kind of wild card here, which is this whole emerging market slowdown that we're apparently at the beginning of in the global economic terms. It's not clear what that's going to trigger in terms of what will happen in Western countries, because obviously a lot of Western countries export a lot of stuff to the emerging market countries. It's not just a one-way trade. How is that going to affect this? We don't have any answers to that. So this leads to the real dilemma, and it has to do with what's irresponsible here. And I think I put this in because initially when I started talking about these issues before the British Medical Journal article about 2 years ago, there were some people who were not terribly happy with the way that I was talking about it. So my response is to say, isn't it irresponsible for policymakers to not think about how you're going to deliver care on a sustainable basis if, in fact, austerity is the new normal? How are you going to, isn't that the issue here, to turn it around, in order to be a responsible policymaker, don't you need to grapple with this, I guess, is the effective way of putting it. There's a lot of pressures, a lot of issues that are going on now in health policy making across Europe. It has to do with structural reform. We've already talked a lot about efficiency issues. The key thing, however, is that there's now growing pressure. I said this was an unhappy discussion. to rethink things that were previously seen as unacceptable, to reconsider what the least worst options are. No policymaker likes to be in that position. This is a long list of the structural reforms that have been undertaken in tax-funded countries, that is to say countries that are, at least in financing arrangements, similar to Canada across Europe. I'm not going to take you through all of them, but there have been many different mechanisms in primary care, hospital care, in terms of re-centralizing control over funding, which both Denmark and Norway have done. National government has taken control over the funding for the healthcare system, taken it away from the regional governments. Oh, did I do something? The issue of patient choice has been involved. All this is now going on in an environment where there's constant efforts to improve quality, to improve safety, to engage in clinical reengineering. That's all going on separate. So it's not that there's nothing happening, but the question is whether it's going to be enough. And how are you going to provide higher quality services? How are you going to solve your problem? Is what you've done to now sufficient? All right. I'm not going to read to you the sections here from the King's speech. This is a seminal event. The Dutch are very proud of what they see as a very generous welfare state. And their king has now come out in a speech, written, of course, by the new government, in which he basically says, we can't afford this anymore. This is the first country in Europe in which the leadership has come out and publicly said, we have a structure of services based on a previous economic error, and we're going to have to reconfigure it. There is a process of change taking place in policy. Very unpleasant statements, as you can imagine, coming from Asia about this. This is from the Dean of the School of Public Policy at Singapore, who is rather sharp in his comments. What he says to the Europeans is, stop living beyond your means. Western leaders are still unwilling to tell their populations the hard truth. The world has changed. Not well received as comments. Does Canada somehow have special conditions and an environment which allows it to escape the kinds of concerns that tax-funded systems are seeing in Europe? Well, to the extent that it's that a large part of your growth is commodity generated, to the extent that commodities go on the international, I don't need to be telling you this, you're a board of trade. There are dilemmas. Oil prices have got all sorts of factors built in various ways, to the extent that Alberta and oil and gas from Newfoundland and so forth are important factors. It's unclear, I guess. I will let you draw judgments on this. So what do? And here, let me take you through some of the policy options. There are 5, and they have to do with least worst alternatives. The first is that some significant part of funding, revenue, cost for healthcare is going to have to shift away from government, shift away from the state, nation state, and onto some form, notice how I said that, some form of individual and collective civil society. Some way or another, there's going to have to be a shift between government and the broader society in terms of where revenues are going to come from. There's lots of ways to do that. One hopes that the government still takes financial responsibility for the worst off, but among the things that can be done, you can shift the state financial responsibility from defined benefit in other words, we give you services, to a defined contribution, which is more of an insurance model, which says we will pay, as in pensions, we will pay up to a certain amount, and that's it. If you want to add additional private funding, you can do that. It requires an individual insurance-based system to do that, so in tax-funded systems, that's more problematic. The whole issue about co-payments, with all of the problems that they have, and they have many problems, we can talk about that at great length, perhaps adding there. Issues about supplemental and private insurance, which a number of countries are wrestling with at this point as they grow. And the whole question about adding to the private sector in terms of insurance funding. So that's stage one, shifting the balance in funding. Second stage, new legislation that encourages private sector health providers. In the tax-funded systems in Europe, most of the curative care is provided by public employees in public institutions. That's starting to change at the primary care level. Sweden, as was alluded to earlier, has already, in the last 6 years, shifted 50%, one half of all primary care visits, out of the tax-funded not tax-funded, I'm sorry, still in the tax-funded system on the funding side, but on the delivery side, they've shifted it out of the publicly employed health centers, the publicly employed provider structure, and they've shifted it to private GPs. Norway moved its entire structure of general practitioners out from municipal public offices in 2003. Into a system of private GPs in their own private offices. So there is this process taking place. The question is, how do you facilitate more of it in a measured way, and how does it become the accepted, intentional policy of government to facilitate this kind of shift, which of course has all kinds of political and social dimensions to it. Third issue is simplifying regulation in order to make this possible, in order to try to create a more diverse system, in order to be less heavy-handed in the bureaucratic fashion. The Swedish government just had the report of an inquiry about how to restructure national regulation for the healthcare system. The title of the report, as submitted, was Make It Simpler, Gorde Enklere. And they proposed taking 12 different national agencies, combining them into 4 agencies, each tied to a specific function. That report was, of course, issued in 2012. As of 2014, it oddly enough, has not seen much progress moving forward. It's funny how national bureaucratic structures tend not to like the idea of simplification and shrinkage. So there are dilemmas, of course, with all these proposals, but nonetheless, that's at least they're aware that they need to try to do it. Fourth dimension is that individuals and patients and families are going to have to take more responsibility. It's going to have to move back to the way it was to some extent. I'm only saying to some extent, in a controlled, directed way, to what was true before government took a larger and larger role. And that means many things about informal caregivers, co-production, the whole issue of wellness incentives, which I'll say a little bit more about when we get to a case study in a minute. Wellness incentives, well, for example, at my university, if you are a smoker, you have to identify yourself as such for the health insurance process, and you then have to pay $50 more per month for yourself. If your spouse is a smoker and is insured by the university, you have to pay $50 more for that person as well. So it becomes $1,200 more for a couple who smoke to get their insurance through the university. If you deny you're a smoker and it turns out later you are, your job disappears. So there are consequences. But that's that's not wellness incentives, that's actually sanctions. Wellness incentives turns it around and pays you to behave better. But those are the that's one kind of issue. I mentioned the informal caregivers, and there are many other issues around co-production of care that individuals can pursue. The last one is another issue that is very unpleasant for European health policy makers who are committed to public sector, public sector activity, which is to expand the role of private employers, to expand the role of occupational health, expand the role of worksite provision, so that they provide more primary care and they take some of the burden off of the public sector, hopefully in ways that involve a trade with social charges so that you don't drive up the cost of labor. That's obviously something you don't want to do in this economic environment. So what does all this imply? If you pull all this together, what are we talking about here? There's an emerging process which is going to be a major shift in the balance between what the state does and what civil society does. There, in effect, would be a new social, wait a minute, a new social compact, a new social agreement between the individual and the state, which means that the individual has duties as well as rights when it comes to health care. That phrase, by the way, came from a senior policymaker in Finland in 2009 at the height of the crisis, because that's what they were talking about in Finland. In other words, you, the citizen, are going to have to be responsible for maintaining your own health. And we're, as a system, going to put some of the obligation on you to do that. It's no longer a situation where you can simply present in whatever condition you do and receive services, because that's no longer financially tenable. That's why I said it was a new social compact. So within that, as I mentioned before, the role of government is to diminish or minimize the social inequities, to support the less well-off, but they too have social responsibilities. They too have responsibilities in terms of maintaining their own health. Very different configuration than the traditional welfare state structure of delivering services based on public funding. We're not talking about US-style privatization. Nobody's talking about a helter-skelter development of a private sector. This is a planned process that the national or regional government puts in place to enable it to achieve the objectives it wants to achieve. It's just using different mechanisms, different tools. Are there going to be implementation dilemmas? Absolutely. Is this the kind of thing that's simple to do? Of course not. You're going to have to engage in a whole different way of targeting strategies. And we don't know if it'll work. That's clear. Okay, quickly I'm going to take you through what happened in Finland when I made similar statements 5 months ago. Case study you might perhaps see some of your own situation in. Finns were not happy, even though it had been a Finnish minister who'd raised the question about the new social compact. Finns inside the health, people who are making decisions in the health system, were not terribly happy with the idea that they had to move into a whole new period. And they said, well, but can't we just reallocate funding? Can't we just become more efficient? That's been the claim for the last 20, 30 years. As I mentioned earlier, how do we do that? That will solve our problem. We use our money more effectively, various strategies. And what I put together was a couple of strength weaknesses charts for them around the difference between reallocating and the issue of diversifying. Diversifying means expanding from public sector into a broader public and private sector mix. And I'm not going to take you through the entire sequence. Hopefully we will post, Marshall, the presentation on the website afterwards. If you want to go and look at how the specifics work, you can take a look at it. But just to give you a couple of highlights here. Strategy A is that you reallocate your funding, you reallocate your personnel, you reallocate your facilities, you're going to make them more efficient. Strategy B is all the things that we've just talked about. That you diversify on the funding side to private insurers, to families, that you have penalties for individual behavior that harms health, like smoking and overweight. Also, high blood pressure and high cholesterol. You start making people responsible for their own health status. And on the delivery side, diversification means basically expanding non-state, non-public institutions in various coordinated ways, but nonetheless, they're no longer publicly run. And you regulate them, but you require light touch regulation. It's not regulation in the way that the Europeans have been doing it thus far. If you look at the strengths of reallocation, there are a couple that are important. You can still shift towards primary care, which keeps WHO happy. You don't have to fire anybody. That keeps the unions happy. You'll notice this is the first time in this presentation I've used this forbidden word in the health policy debate, unions. But I'll stop. If you diversify, also it means that the public sector, either the national government or the regional government, retains control over the funding and delivery process, and that keeps the politicians happy. So that's the advantages or the strengths of reallocation. The weakness is, of course, that nothing changes. The Swedes have a wonderful phrase for this. They call it, in English, it's change process, förändringsprocess. When I started going to Sweden in the early 1980s, everybody was busy getting doctors in particular and social workers across the divide between health and social care, this whole issue about elderly care and chronically ill, and getting them to sit around a table, the doctors and the social workers, and they would have a förändringsprocess. And the problem was that it was almost all process and very little förändring, which means change. It never changed anything. Nobody had any reason to change. Everybody had a fixed public salary. I said I wasn't going to say anything about union. I won't say anything about unions. Everybody had a fixed public salary. Everybody had a fixed public retirement. Everybody had a fixed 40-hour working week. Why would you want to do anything which would complicate things? So this notion that somehow you can keep things in the existing structure of governance and you can make major changes raises some questions in my mind, given past experience. It also assumes no reduction in public money. It really assumes that you're going to have the same amount and perhaps more funding. And it also ignores the fact that the international standard of care continues to rise. And that's a real problem. In particularly the Nordic, but also most European systems. Their cancer care is constantly behind the major international standard. There are constant revolts of various kinds from patients. Their 5-year outcomes are not good. It's one of the issues that is very much a hot button and not just in the tax-funded systems. It's also true in Germany. It's true in France. It's a real problem in general out of systems that are largely publicly run. All right, we turn to diversification. The strengths of diversification are that you have the ability to increase innovation, entrepreneurship, you bring in new clinical approaches, you reduce managerial bureaucracy. Those are two things I would highlight. The weaknesses, however, of diversification, not only does government have to change its spots, it has to change the way it regulates, but you're inevitably going to have more inequality, you're going to have more fragmentation of services, and the public sector has less leverage over physicians. So there are a lot of issues that one looks at. Where does this leave us? How does one summarize this? And I thought long and hard about this next slide because in some ways it's a little bit sacrilegious in the health environment, but I think it captures the nature of the situation in the European context. You'll have to tell me about the Canadian context, which is, if you're going to have sustainable health reform, it appears that it's going to go through 5 stages. The first stage, which is the one that most European countries are still in, is denial. As people begin to realize that this may be the new normal, we do see some movement into anger. Thus far, there's been very little bargaining. In other words, well, how do we get out of this situation easily? You hesitate to think about what it means for a healthcare system to plunge into depression. However, that could be part of the development, and then one hopes that there is a rapid movement towards acceptance that the environment, the world, is a different world. We're in a different era, and then you move forward and try and find new ways to reach your old goals. So I leave you with that thought. Thank you.
Great, thank you. I think I've got a... Thank you so much for your remarks, Professor Saltman. I'll ask you to remain on the stage, and we'll start to pull up some of the questions from the interactive pigeonhole technology that you heard about earlier today. Those are results that we'll display up here on the screen, and there's lots of questions already, lots of people with interest. While we're waiting for this to come up, I'll just give a short introduction of myself as a co-chair today. I'm Dr. Marshall Dahl. I'm a clinical professor of medicine in the Division of Endocrinology at the University of British Columbia. I'm a consultant at Vancouver Hospital. I'm a former chair of the British Columbia Medical Association and Canadian Medical Association's Councils in Health Economics and Policy. That's why I'm here today. So let's have a look. We're going to look at our link on the pigeonhole. I'll move aside and give you this back. And basically, people are voting, so if you have a look now at your smartphones, there's still a chance to go for your favorite question.
This is serious work.
This is serious. We're putting you to work here, Dr. Saltman. So up to the microphone, if you'd be so kind. And the top vote getter, right from the start, has been, how can funding and provision be structured to encourage more preventative behavior and intervention? And that should project for us in a minute. There you go.
You've put your finger on one of the sensitive points of this whole process. If, in fact, we want to improve prevention, we want to move farther upstream, maybe not as far upstream as the Marmot process, where we redesign housing and restructure jobs, but upstream in the sense of prevention for immediate health conditions, some of that obviously takes place if you put responsibility on individuals to take that role themselves, if you can structure it correctly. But generally speaking, the challenge is to find ways in which you can do something that health systems have great difficulty doing. Do something new without spending new additional money. In the late 1980s was when the first issues of dealing with prevention became important in health systems. And there's a famous event that took place at a Harvard teaching hospital where some professor of public health, somebody like me, came and started talking about how important prevention was and that the emphasis was going to shift away from clinical services. And a cardiac surgeon stood up and said, "Excuse me, I do prevention, I prevent death." That gets at the core of the dilemma, which is that in some ways prevention in one way or another is built all the way through the clinical structure. How do you get the types of prevention that you want, which is to keep people out of the downstream curative care system? How do you keep them away from that cardiac surgeon? Not keep them away, but prevent them from needing to go. And in this environment where reallocation probably is not going to work terribly well, how do you diversify responsibilities for that? Here, we're in an area where I can revert to the classic mantra of many healthcare consultants, which is to say that you're going to need innovative leadership, you're going to need new models and tools, and then, of course, I don't have any further to specify. But this is a discussion that clearly needs to be held.
Well, thank you. Our next vote getter here is there a health system in the world that at least approaches a sustainable and affordable funding model and has good health outcomes?
For who? All healthcare systems work for certain people better than for others, certain people in the society than others. That's an unfair response to a very good question. The question has to do with, are there any models really out there? And I'm wondering if there are any models of process, of trying to work with the nature of the changes that are necessary at the national level, at government levels in Europe. And at this point, I guess the closest that I can think of would be Denmark. The Danes have tried to do a number of things in their reforms starting in 2007 that to some extent fit with the kind of picture that I'm presenting, but only to some extent. They are not really adding, they're not diversifying additionally on the private sector. They're still basically trying to reallocate inside the public sector. But one thing the Danes did, which is interesting, when they restructured their system and pulled funding away from the regional level, that should sound, of course, it's a small country. Denmark's 5 million people. I don't think this is a model that the Canadian national government would want to consider. But the Danish national government pulled funding back to the center. They also required that 20% of the funding that they would now then spend out would go not to the regional level, but would go directly to the municipal level and would be targeted for prevention and for primary care. And they got municipal level government involved in developing new preventive services. Having said that, that's a kind of structural, well, that's really reallocation within the old public model. I've yet to hear a lot about innovative new strategies coming out of that. One thing, though, that the national government required the municipal governments to do, which is innovative, is they started paying GPs more for doing workups for chronically ill elderly, particularly for diabetes patients. Their numbers were not good. That the typical diabetes patient, what was it? 40% of all diabetes patients had proper workups. So they required the municipal governments to pay the private GPs an additional sum of money for a workup, initial workup, and then the GPs received a premium for being paid more to do an annual assessment of each diabetic patient with an idea of trying to get the rates up to more like 90% of coverage of diabetic patients in Denmark from 50%, with the idea of keeping them out of the hospital. But again, they're spending more money. You don't save any money in the hospital to any real extent in a public system if diabetic patients don't turn up in the emergency room. You still have to pay all the fixed costs. You still have to pay the personnel costs because everybody's on salary. So there's no savings that can be reallocated upstream. So it means you have to spend more money. And that's why I'm hesitant to say that's an example.
Well, thank you. I think the next question has to do with the fact we're working in an environment with a large single-payer healthcare system, and people have discussed the role of private systems. And so this question was that, well, the United Kingdom has had a parallel private medical system and a large central public system for decades. Does that system work?
There are many different responses to that question. If you are interested in pursuing this, you can go to the Financial Times online, ft.com, and you can look at the sequence of stories over the last 2 or 3 years as the British National Health Service grapples with the fact that it doesn't have enough money. The squeeze is very serious. The public sector is seen as being at risk. Having said that, even with the current conservative government, for a whole series of reasons, there has been no decision taken towards a new broad strategy that would fit. The UK policy debate also is one of the most contentious probably in Europe. They're still fighting the 1980s issue as to whether private sector is a has devil's horns, and as a result is something that should be proscribed, something that should be prohibited. That debate has largely disappeared in the rest of Europe. It's become much more a question of what works, what mix, how do we make it work. Very pragmatic debate about public and private now, and not just in the Nordic countries, but even in the more ideological Southern European countries. The debate has largely calmed down. England is the last bastion, the last holdout of 1980s opprobrium, the screaming and yelling about how terrible the private sector is. So that's one reason the conservative government has not tried to address the problems of the NHS in a more systematic way. At this point, does the model work? I guess what I'd have to say is that in the current context, there's a distribution whereby there is a private sector structure, and it does receive funding from the public sector. One of the last things that the Blair Labour government, left-of-center government, did before it left office was to require that when a patient is referred to hospital from a general practitioner, that they be given a private hospital as well as a public hospital to choose from in terms of where they want to go, and that public money would follow them. So there have been efforts in the past. I don't want to diminish those. But at this point, does the model work? I think what I'd say is the model's under serious stress, and even, well, perhaps I should say it differently. Unless the UK economy surprises everybody and grows dramatically in the next couple of years, I think you're going to see some major changes take place in the UK.
Okay, thank you. I think the next question arises out of the Canadian context with the knowledge that when Medicare was set up some decades ago, it really was designed to cover doctor and hospital services, not pharmacy, not other things like that. And this question is, well, then why do we insist on stating that Canada has a single-payer system when, in fact, patients and private pay actually covers about 30% of all healthcare costs and arguably receives lesser standards of care? So I guess the corollary of that is, do you agree? How could we do better? Are we underperforming?
Well, I think, as I said at the beginning, my knowledge of the Canadian healthcare system has atrophied a bit since the time that I was involved in Quebec and Ontario in the late 1990s. I'm trying to remember the name of the gentleman who led the major reform report in 1991 in Quebec. There were a number of activities. So I would really have to defer to the audience in terms of how you define the Canadian system. I know that there has been efforts at change in some structural sense in terms of decentralization, and then in Alberta, re-centralization. There's questions about how to integrate various existing private services, CT scanners in Alberta and so forth. There are bits and pieces, but I guess my perception is that the healthcare system, costs and process south of the border have served to restrict, diminish, and steer the debate in the Canadian context, because you sense that you do not want to go the way the United States has gone, and that probably has had a major factor. I guess I'm concluding by saying that I would defer to your answers as to why that is the case.
Okay. Well, I think we have time for one more question. It's an important question, too. A lot of votes. During health system austerity and cutbacks, how are poor members of society going to be protected?
They're the ones that should get the lion's share of public money. Pretty much that simple. They still are going to have, I would think, responsibilities in the same way that other citizens have responsibilities, which is going to shift. I don't see how you can create categories in which you say middle-class people are going to be responsible for their health, but we have special groups in the population who are not responsible equally for their health. Again, this violates all of the standard thinking. If my good friend Bob Evans were here, he'd be standing up throwing books at me at this point. But in the environment that we're going to be in, there's going to be this shift in terms of civil society individuals taking more role, more responsibility. That's going to include lower income and those who are still mentally competent. I'm not in any sense implying that it covers all the full range of vulnerable patients. The issue is going to be how you do this without creating two tiers, how you do this without creating the argument that has been used for many years against splitting up universal systems, which is that if you have health care only for the poor, it will be poor health care. Those arguments are strong arguments. It's going to require some substantial, innovative thinking in terms of how you escape from those dilemmas. Having said that, the pressures are not going to go away in my understanding of what's happening to the public systems. And we're going to have to rethink what the configuration is going to be, and that is going to have to include, to some degree, the less well-off members of society.
Thank you very much. Well, Richard, I'd like to thank you very much for these insights today. We're looking forward to having you back on the first panel in the question and answer period a little later in the morning. I mean, we're really appreciative of you taking the time out of your schedule to travel here and fly with us. And on behalf of the Vancouver Board of Trade and sponsors, we have a small token of appreciation for you, courtesy of Purdy's Chocolates.
Thank you very much.
Everybody's favorite. Thank you so much. Thank you. We'll take a chance to talk.
I appreciate it.